Okay, so good evening everyone. I guess I'm audible and visible. I'm on live, I hope. So everything okay? You can simply write in the comment. We'll continue with. So everything fine? Shall I continue? I guess it might take some time for me to go on live. So shall I continue? Everything fine? Am I audible? I cannot see the chat and response. Okay, so yeah, so I guess I'm connected and I'll discuss the surgery question now asked today in INICET exam. One thing I observed, the questions were little simpler as compared to other subject as compared to previous exam. और कुछ क्वेश्चन तो वो एट पार विद फॉरेन मेडिकल ग्रेजुएट एग्जाम. सो डेफिनेटली द लेवल वाज लेस एंड again there's no chart is not visible. Just give me 1 second, then we'll start the question. Yeah, so one question was MRCP image, straightforward question. Can someone tell me the fourth option? I would like to collect all the options so that we can make a video with authentic answers and authentic options. So can anyone write the fourth option here? MRCP image given and they ask for the diagnosis. Obviously the answer is CBD stone. So this question, not particular this question, but the approach and MRCP image I showed you in TND as well as in certain grand test also. So can anyone give me, I cannot see the messages, I don't know why. Okay, so that was one question. The second, this is an overlap between radiology and surgery. So anyone help me in finding the fourth option here? Okay, the second question was not a perineal approach for rectal prolapse. And Altamir, as you know, is perineal rectosigmoidectomy. Thiersch, first thing around the NS. Delorme, plication of muscle. These three done by perineum. This is not done by perineum. This is done by laparotomy or laparoscopy approach, where we fix the rectum posteriorly to the sacrum. This is my lecture when I showed you the images also in lecture, in regular batch. Delorme, Altamir, Thiersch, these are the perineal approach. And for abdomen, rectopexy, Wells, which is Ripstein, and Dehoor, which is lap ventral mesh rectopexy. All this surgery we have discussed in regular batch as well as in images also I showed you. Now this is the third question. Identify the condition. The normal gallbladder shape is like this. Again, I cannot see the chart, so I think I'll wait for some time. There may be some glitch or something, but I'll connect it again. Okay, so this is the normal gallbladder where we have fundus, body, neck, and this is called Hartmann's pouch. While sometimes we have a shape like this. This particular pouch here or a septum making two couches of the gallbladder, this is called Phrygian cap. This also I have taken few centers gallbladder liver lecture. Most of the center probably got up to the lecture. So this is the image I showed while taking the lecture. This is the Phrygian cap. This is a cap called Phrygian cap. It identifies it It's similar to Phrygian cap. So this is the image here of Phrygian cap here. So one question again, radiology and surgery overlap, Phrygian cap, gallbladder, and it's not pathological, it's just shaped like this. So rather than gallbladder having a shape like this, it is having a shape like this. This is called Phrygian cap. Now another question was elderly male with bleeding per rectum, which investigation is not done? Actually at postgraduate level or PG level like MS exam, I'll get all 4 done, but in undergraduate level, I'll not order this. CEA is high in more than 80% of colorectal cancer, which is a glycoprotein. We discussed the approach of rectal cancer very thoroughly in colon cancer. Colonoscopy is the investigation of choice. And CT scan or PET CT is best to know the staging. While CA19-9 is a marker for pancreatic cancer as well as gallbladder cancer, cholangiocarcinoma. So in pancreatic cancer, it is high in almost more than 80%, gallbladder cancer more than 70%, while in colorectal cancer, it's only high in 30%. So it's not a regular marker we order. Of course, in tertiary center, it's also done, but not in undergraduate level. You can simply say this is not a marker for colorectal cancer. Bleeding PR, we presume that this is, we are talking about cancer. All investigation here are mentioned here are for cancer only. So CEA, colonoscopy, PET CT or plain CT are specific, very important investigation for bleeding PR colorectal cancer, while CA19-9 is not totally done. As I said, it's signed 30%. It's a CEA is a glycoprotein, while CA19-9 is a murine monoclonal antibody. Normal value less than 37. We have discussed that in regular batch in gallbladder cancer and pancreatic. So it's not regularly done in colorectal cancer. But yes, in some cases it may be high. Out of these 4, it is the least likely investigation to be helpful. Now, 2 hernia questions were there. Can someone, in this question, Khush saying multiple correct? So, no, not multiple, it's saying not done. So, this is not done. Rest 3, we definitely do. Out of these 4, it's not done. Even if multiple answers were correct, only this is the right answer for you, only one option. So, 2 hernia questions were there as I've been told, but I do not know the details. One was a hernia image, the same image probably given, then this is the same image which I show in hernia lecture. Last week only I took lecture in Rajkot, I showed the same image. And of course this is a sliding hernia. Sliding inguinal hernia means like this is the sac, bowel inside. Now something protrudes through the internal ring by the side of the sac, not a content of sac, forming the wall, which on the right side can be either cecum or bladder, on the left side bladder or sigmoid. So a cecum coming down, forming the wall of the sac is of course sliding hernia. I guess this was a question. There's one more question of hernia. Can someone write down the question? What was the second question? Now one option here is reduction in mass. Now this is something probably incarcerated means obstructed hernia. Now this word probably you're not aware of, where the hernia is, this is more, it's not seen in inguinal hernia. It's more often seen can be seen in inguinal hernia, more often in ventral hernia or in femoral sometimes. You see, the whole hernia has been reduced with a closed neck. So the obstruction is not relieved, although the hernia has reduced. This is called hernia in reduction in mass. So yeah, if the hernia was reduced with sac, then this is the answer. Then this is the answer. That's why I kept this image also. Then this is the answer. If I think image was like this, Anushri, if it was like this, then reduction in mass is the answer. So thank you for telling me this particular, option. I was under the impression that sliding hernia was asked. Now see another question. Not an advantage of ultrasound over mammography. Okay, Ramkishore, thank you again. So this is the reduction in mass here. Okay? Yeah. So this is more of a common sense, this question, rather than medical, we don't need medical information for this. Too deep knowledge. I mean, very superficial knowledge will suffice here. Not an advantage. Obviously, to differentiate cystic and solid, ultrasound is best. It does help in taking the biopsy, ultrasound guided biopsy. In young female with dense breast, mammography is useless. MRI is best, but ultrasound also is the first test. While it can be used for mammographically undetectable palpable breast mass, that's not correct. Mammographically undetectable palpable breast, well, this is also somewhat correct, but carcinoma in situ, comedotype, etc., you cannot see on ultrasound. The best is mammography. So out of these four, I would say D is the best answer here. Rest three, of course, ultrasound. By default, by exclusion also D becomes the answer. First three, of course, ultrasound is better. Which is not true about breast conservation surgery. While local excision and axillary section done, that's correct. You take 1 centimeter margin and you can do axillary section or you can do sentinel node biopsy. Both are done depending on the case. Frozen section may be needed to confirm the negative margin, while radiotherapy is must in all cases. Without radiotherapy, breast conservation should never be done. It has unacceptably high risk of recurrence, so radiotherapy, after one of the clear-cut indication of radiotherapy is all cases of breast conservation, which of course I kept one question in grand test also based on breast conservation, where I told you the indication of radiotherapy. So here B is the answer. If you have any correction, anything, you can write it down in the chat. Now, one question which was matched the following was based on the position of appendix. This, of course, we discuss in appendix regular batch. Retrocecal is the most common, around 60%. Pelvic is second most common, around 25% or more. Rarest is post-ileal, which is 1%, followed by pre-ileal 2%. And this is subcecal, which will give Cope obturator test positive, while retrocecal will give Cope Swas test positive. We can have one more position, paracecal, by the side of cecum, which of course is quite rare. So I do not know the exact options here, but it was matched the following and the image was there. Now in this question, image may be different from the exam, but the question was there is dysentery 6 weeks back. Now dysentery with a hypodense lesion in the liver clinches the diagnosis. So there is a right upper abdominal pain with dysentery and hypodense lesion in the liver. Of course, it is amoebic liver abscess. So this question I've kept in TND this year, where I told you the difference in amoebic and pyogenic, and cluster sign you get in pyogenic abscess, while not target, we call it double ring sign, you get in amoebic abscess, though it was not the question, but dysentery and hypodense lesion in liver with pain right up abdomen, of course it's amoebic. Hydrated, the two sign you need to remember are cartwheel sign and water lily sign. We had one question INICET last month only, 2 months back. And for hemangioma, we have peripheral enhancement, the dye getting collected in the periphery. All this, of course, we have discussed already many times in grand test, in TND, etc. Varicose vein, test for saphenofemoral junction incompetence. Vascular disease I discussed at very few centers. One center was Lucknow, there was one more center. And the examination I told you very categorically, Trendelenburg test is a very good test to know the saphenofemoral incompetence. Suppose this is a femoral vein, this is the long saphenous vein, this is the main perforator incompetent, these are the other perforators. You simply elevate the limb and empty the vein, and you apply tourniquet or block here. Ask the patient to stand. If the vein does not reappear, doesn't become prominent, you have already occluded here. So if the vein does not reappear, it's main vein, main perforator incompetent, main valve incompetent, and if it reappears, means blood coming from here. and this is the perforator incompetent. So differentiate between septal junction and perforator, Trendelenburg test is done. Perthes is to differentiate to rule out deep vein thrombosis, chronic deep vein thrombosis. Morrissey is not done anymore. That was also for FSJ incompetent, but that was cuff impulse. It's an old test, not done anymore. So Trendelenburg is the best answer here. This also was a question in grand test last year. Out of 10 grand tests, one was Ranelagh. So Ranelagh, if multiple answers, then both. This is correct, this is correct. Ramkishore, thanks again for telling me, because this is also for SFJ incompetence. Though it's not done, you see the cuff impulse at septal junction. If it's incompetent, you can feel the cuff impulse. Perthes is not done, and Fogan is the defect in the fascia, but that's also not very good test. A and C is the best answer here. If multiple answers are correct, then A and C both are correct. If only one you have to choose, then best answer is A. Now, cystic, Ranelagh means frog belly. Rana Tigrina, Rana word. Frog belly, like belly. So this is Ranelagh, which is retention cyst of submandibular gland more often, sometimes sublingual gland. Both can form this. Cystic hygroma can be big enough to cause a swelling at the floor of mouth. It can be big enough, but obviously the more prominent swelling will be in the neck, as well as branchial cyst also is in the anterior border of sternocleidomastoid, while cystic hygroma in the posterior triangle. Dermoid, of course, it's not a dermoid. So right answer is Ranelagh. And there was a question in grand test. I kept deliberately a photo of Ranelagh and how to differentiate from torus mandibularis also I told you there. Not a complication of TPN. Now this is a simple common sense question. Total parenteral nutrition. I'm not putting anything in mouth. I'm not putting anything in the stomach. So why the aspiration should happen? Pneumothorax, yes. While putting the cannula, one can penetrate the pleura causing pneumothorax. Refeeding syndrome is a very common problem. The sugar, the potassium, everything goes from extracellular to intracellular compartment, including the phosphate. Most important, of course, is phosphate, causing arrhythmias, etc. Osteoporosis, yes, calcium deficiency can happen. Aspiration, we will never get in TPN. So obviously, it's the answer. Smoking is not a risk factor. Smoking is associated with all conditions of breast except fibroadenoma. Fibroadenoma is a part of aberration in normal development and involution, where aberration in normal development. So it's basically a condition of young female, 15 to 35 years. Aberration normal development can be intraductal or periductal with breast, mouth, very mobile, firm lump. Mondor's disease can be precipitated by smoking. One more condition, Zuska disease, Zuska, Z-U-S-K-A. Periareolar mastitis in old female, very strongly associated with smoking. Z-U-S-K, Zuska. It might become MCQ in future. Cancer, some books say it's not a risk factor, but some books say 1.6 times risk is there with cancer. Davita say there's a risk with smoking, so you should consider smoking as a risk factor. Though some books say it's not a risk, but I'll consider it as risk. Endocarditis also is associated with smoking, while fibroadenoma is not at all associated with smoking. Hemorrhage with road traffic accident, patient comes in emergency with suspected pelvic fracture and hypotension. This especially, I discussed this topic, I elaborated this in detail at the center where I took trauma lecture like Lucknow and some places. No, Lucknow, I'm not sure, but some places. And this, I told you that pelvic compression has been removed in ATLS new guideline. And the first thing that you do, I showed this image also, you tie the binder around the hip because patient can die due to hypotension and pelvic fracture. I showed this image before and after compression of pelvis by binder, right? This is, you can simply use towel clip and bring the pelvis together. The open book, you simply close it. And the moment you do this, pelvic stabilization by binder, by sheet, by anything, you stop the bleeding. If bleeding doesn't stop, only then you do laparotomy and go for internal iliac artery ligation. But that's the second step. And this question I specifically showed you in grand test also. I kept this question that patient have a motor vehicle accident, he is hypotensive, he moans on pelvic palpation, what is the next step? And the answer was pill place. This is the same question I kept in GT, grand test, last year of course, placement of pelvic binders. So this is the first step you do. But remember, pelvic compression has been removed in new edition of ATLS guideline. Two things which has been removed. One is pelvic compression, second is per rectal examination for high floating prostate. That has also been removed in new guideline ATLS, which of course I've discussed earlier when I discussed trauma. So this is a very important question which I kept in grand test also, and I discussed in places where I discussed trauma. The first step will be this. Okay, and I'll show you an image. Remember the image also. This. Here. This. Plus X-ray. Before, see the open pelvis, and after. Simply binder. No fixation has been done. Right? So the answer is A. This image was shown. This is a right angle forceps called Mixter. M-I-X-T-E-R. This also, when I was active in Facebook last year, in the beginning of last year, 2022 beginning, I posted this image on Facebook, DAMS exclusive club, Mixter. Very common instrument used in surgery. Like I have to ligate CBD, I have to ligate incolsectomy. This is what we use, right angle, pass behind the cysterectomy. Assistant will give a thread, you hold. This is a very common, very important instrument. I think that's it. These were the questions I could gather. If you have any other doubt, query, any question, feel free to ask. Any question, I'll just wait for a few minutes. If you have, because there's some lag, there's 30-second or 1 minute lag. So if you have any query regarding any question or anything else to add, feel free to write in chat. So that's it. All the best to all of you. I guess you have done it. And be confident. These are very simple questions, common sense questions, not very technical. And normally INICET level is very high. This year the level of surgery at least. Yeah, good. You told me one option, but that's not the answer. So you said one option was external. Explore and reduce immediate reduction. Yeah, there could be one more option, I'm not sure. But the answer is, of course, tie around the hip and trochanter. That is what you do in emergency. Thank you, Bhavana. Drug of choice, trastuzumab, resistant R2. Can you tell me the option, Ramkishore? Was there a question emtansine, R2 emtansine? What was the option? You see, you have to tell me the option. Breast I have taken very few lectures, but the lecture, like some places I have taken breast. So I told you the new drugs for breast cancer. HER2 new, trastuzumab, pertuzumab. If recurrence within 6 months, then you give trastuzumab and emtansine. Other drugs. So can you give me the options? Imatinib was one option, okay. What about the other option? Lapatinib, sorry, lapatinib we do give. Lapatinib we give, but we have to know the other option to tell you the right answer. Lapatinib is fine, we give lapatinib. Was pertuzumab was also option, Ramkishore? Pertuzumab? You cannot reconnect? Okay, fine. I'll try to gather the options and I might make a video because these are the question I had. So, for HER2, basically the 3 drugs which are approved are trastuzumab, pertuzumab and lapatinib. And then if there's a recurrence, then we go for M-tansin, trastuzumab plus M-tansin. So I have to know the exact question and option, then only I can tell you the answer. If PD-1 and PD-L1 was also there, then probably we can go for pertuzumab. Was PD-1, PD-L1 positivity was also mentioned in the question? Duke of Hazard, wow, good name. So, PD-1, PD-L1 was also there in the question? No. Then I think lapatinib could be the answer. Then I think this is the, out of the whatever options I have, I think lapatinib is a probable answer. Erlotinib, no. Verafenib, no. Then lapatinib is the answer. Erlotinib we give for a few cancers in surgery, like in pancreas we give and some more. Fine, so I think that's it. And all the best to all of you. We'll wait for the result. I'll wish you all the best. Not only for this exam, for all future endeavors. So I am going offline now. And be happy, be blessed. Good night.